This conference will now be recorded.
Yes. ಆಗ್ತಾ ಇದೆ.
This conference will now be recorded. This conference will now be recorded.
People can start.
Yeah, good afternoon, everyone. Yeah, since last 2 days we are doing this Webi Criticare 2020. We have started with neurology. We have done with the traumatic brain injury, as well as we have done yesterday with the ischemic stroke, how to manage ischemic stroke. So today we are going to discuss on intracerebral hemorrhage. Because of the time factor, we may not be able to cover subarachnoid hemorrhage. We'll try to do with intracerebral hemorrhage today only. So we have two efficient speakers, and also expertise are here actually. So as we discussed yesterday with acute ischemic stroke with Dr. Shushruth, sir is here to discuss about intracerebral hemorrhage. I want to introduce once again, because who have not come yesterday, they can come to know Dr. Shushruth sir is American board certified neurologist, as well as American board certified vascular neurology. Sir is a stroke specialist. Sir has almost 15 years experience in this stroke field. So sir has done a lot of several controlled trials actually, and also sir has written a lot of articles on stroke, and it is there in the even well-known books in United States of America. There, sir, articles are present in those books actually. Thank you so much, sir. I welcome you. And also we have one more expertise today, Dr. Vinayak Kadlimati. Sir is a neurosurgeon, and also sir has done fellow in neuroendoscopy. Sir is well-known neurosurgeon here, and sir is associate professor, JSS Medical College, and visiting consultant neurosurgeon at Gopalgoda Shantavari Memorial Hospital. Sir has done several surgeries in this intracerebral hemorrhage and as well as subarachnoid hemorrhage. We wanted to discuss that part, but somehow today we are not discussing, and definitely will come up with the subarachnoid hemorrhage again. Welcome you, Dr. Vinayak sir. Hello, Vinayak sir. Vinayak sir. Okay, we will start the session. I will go to Dr. Sushil sir. Please take over, sir. Thank you, sir.
Thank you, Dr. Raghunath. So today we'll be discussing about intracerebral hemorrhage. So yesterday we discussed about ischemic stroke. So this will be a continuation of a management of stroke. Yesterday we discussed that types of stroke are ischemic and hemorrhagic. Majority of them are ischemic stroke, almost 85%, and 15% of them is hemorrhagic stroke. Most of the time, the intracerebral hemorrhage is secondary to hypertension, and when a patient present with the lower hemorrhage, then cerebral amyloid angiopathy should be taken into consideration. The amyloid angiopathy is the second most common cause of intracerebral hemorrhage after hypertension. Then there are other causes which include aneurysms, some vascular malformations, but the rarer causes of stroke you also need to know, because sometimes you need to treat the underlying comorbidity along with the intracerebral hemorrhage. For example, if it's secondary to infection like herpes encephalitis, or it can be due to vasculitis. So we need to know about the other etiologies of stroke. The stroke, as a hemorrhagic stroke, can also be secondary to venous thrombosis. It can be due to hemorrhagic infarction. Sometimes it can be due to infective endocarditis leading to septic embolism, and rarely drugs can also play a role. Very important thing is also medications. because when the patient is on aspirin or dual antiplatelet therapy along with acetylene or other anticoagulants, that can also play a role. So we need to get a proper history to identify the underlying etiology of the stroke. Regarding the mechanism of injury is concerned, it can be due to the damage to the brain can be due to direct mechanical effect. It can be from the expanding clot itself, which also causes perilesional cytotoxic edema that lead to the mass effect and increased ICP, which in turn reduces the cerebral perfusion, and then you can have subsequent cerebral herniation. The indirect effect is by breakage of the blood-brain barrier, which will lead to vascular edema or vasogenic edema. So in the initial phase, the major damage will be from cytotoxic edema. Subsequently, there will be vasogenic edema as well. Regarding the location of the intracerebral hemorrhage, as with your experience, you can say that majority or more than 50% of them are in the subcortical area, which is the basal ganglia area, which includes putamen and globus pallidus. It's almost 58% of the stroke is in this location. The next common one would be the internal capsule, and combined internal capsule, external capsule form another around 50 to 60 parameters. Then you have lobar hemorrhage, and also sometimes brainstem, especially in the pons, you can see intracerebral hemorrhage. As you can see in this picture, there's the putamen bleed is the most common one, along with globus pallidus. You can have thalamic stroke. Then you have subcortical area with intraventricular extension. As you can see in the lower bottom in picture D, that you have pontine hemorrhage. And you can also see cerebellar involvement with the intracerebral as well. And lastly, you can see that there is a lobar hemorrhage, mainly in the temporal lobe. Regarding the clinical picture is concerned, patient present with focal neurological deficit. Depending upon the location of the bleed, patient will present with those particular symptoms. For example, if it's due to putamen, will have opposite hemiplegia, some gaze palsy, and patient can be in, if it's a bleed is very big, then you can have a coma involved as well. If it is due to internal capsule injury, then you can have contralateral hemiparesis and some sensory deficits. Same thing with thalamic. But when it's due to lobar hemorrhage, depending upon the location, you can have some opposite contralateral symptoms. But when you have occipital lobe stroke, you can just be having some homonymous hemianopia with no major neurological deficits, especially weakness. And when it's involving the pons, then you can have total paralysis, and sometimes patient can be in deep coma, especially by damaging the reticular activating system. When the pontine bleed is in the midline and it is extensive, you can even get locked-in syndrome picture as well. But when it comes to infratentorial, especially in the cerebellum, most of the time you have imbalance, ataxia, and patient will have severe vomiting and headache due to the brainstem compression. Coming to the diagnostic evaluation of stroke, the most important imaging modality will be a CT head. That's enough to diagnose whether the patient is having a bleed or not. Sometimes if it's an issue, getting a CAT scan, then MRI brain is an alternative. You would definitely need CBC to look at the platelets, hemoglobin. You would need coagulation profile, and also you need blood glucose as well, along with RFT and other regular labs. Troponin is also warranted. Sometimes you can have cardiac stress. Drug screen is important in certain cases, and other routine investigations are mandatory. This is just a flow sheet how you approach a stroke, especially intracerebral hemorrhage patient. When you suspect the patient is having a bleed, in many hospitals we have the stroke team, we have CT should be informed, neuro ICU person should be informed, the charge nurse of the emergency room should be involved. So, and also at the same time, neurosurgeon should get a kind of a warning phone call saying that there is a possibility of intracerebral hemorrhage patient, and we will be in touch with them depending upon the CT imaging finding. As with any patient, you would check the airway, breathing, circulation. Once we get the regular labs, you would keep the patient on oxygen if the saturations are low. You do a brief neurological exam and urgently shift the patient for CAT scan. Depending upon the intracerebral hemorrhage on the CAT scan, then we can decide about how aggressive we need to control the blood pressure. We are going to talk about the blood pressure in the near future. So this is just a flow sheet. You can use drugs to aggressively control the blood pressure. And if the patient is on any blood thinners, you would give some reversal agents. And also, depending upon the ICP or the mass effect, you would consider either the mannitol or hypertonic saline to reduce the mass effect. Last but not the least, if the pressure is pretty high, if there is ventriculomegaly, there is significant midline shift, obviously neurosurgery should be involved, and they can decide whether further procedures needs to be or intervention needs to be done or not. If there is no surgical indication, then the patient will be admitted for conservative management. The approach of intracerebral hemorrhage falls into these few categories. First is general measures. Next is blood pressure management. The third one would be reversal of anticoagulation. ICP management is very important. Then you would do the general medical care. Last but not least is seizure management and prophylaxis. The general measures, it's as with any stroke patient. Head end of the bed should be elevated at 30 degrees to prevent aspiration and also help with the ICP. Patient should not be dehydrated, so using normal saline would be sufficient. Obviously, we are discontinuing all the blood thinners. If the patient is on anticoagulants, immediately we need to reverse the anticoagulants. For example, if the patient is on heparin, you would do the protamine sulfate, depending upon the heparin administration. The dose and duration of heparin administration is very important, because if it's been given in the last few hours, then you would go with 1 milligram of protamine sulfate per 100 units of heparin administered. But if it's longer duration, heparin was given like more than 8 or 10 hours, then you would use much lower dose of the protamine sulfate. Enoxaparin, same thing, you can use protamine. If the patient is on antiplatelet therapy, initially the thought process was to give platelet transfusion, but recent study have discounted that effect. They say that it can be and it should be avoided. Yesterday we talked about TPA. If there's a bleed associated with TPA, you can either use cryoprecipitate or you can use tranexamic acid. And then platelet transfusion should be considered if you are planning for a procedure, especially intervention from neurosurgery side. This is just a flow sheet to guide us if the patient is on anticoagulation, especially acitromycin or other vitamin K antagonists. We would give vitamin K 10 milligram IV once push. Depending upon the INR, we can use K-Centra or other FFPs and other fresh frozen plasma and other reversal agents. If the patient is on dabigatran, then there is a specific reversal, the Praxpine, which you can be given. This is a specific agent for Pradaxa or dabigatran. If the patient is on rivaroxaban or apixaban, the newer anticoagulants, then you can use, if it's very short duration, patient has ingested, then you can give activated charcoal. And also, if reversal with other agents, including K-Centra, can be used as well. Prothrombin complex also can be used. So reversal is extremely important, because unless we correct this, the patient will continue a hematoma expansion in the brain. Next most important thing, or the key important aspect in intracerebral hemorrhage, is blood pressure control. before 2000, before the Attack 2 trial, and I was also part of the multi-center trial called Attack 2. This was done in, I was part of this trial in the University of Florida. We had enrolled 2 patients in this trial. So what it showed was bringing down the blood pressure aggressively to around 140 was beneficial in the hematoma expansion. Even though the outcome was not different, it definitely helped in the hematoma expansion. And that is extremely important because in turn, mortality can be prevented or at least minimized. So current guidelines were changed. So now when the patient's blood pressure is around 220 and below, you can aggressively drop it down to 140. Further drop can be dangerous sometimes. It can cause renal adverse events. So you need to be careful not to drop it too low, especially less than 140 to begin with in the first few hours. Later on in the next 24 hours, you can start lowering to whatever level you want to. But at least in the first couple of hours, 140 would be sufficient systolic blood pressure. And again, in the systolic blood pressure, if it's more than 220 on presentation, then optimal goal would be to bring it around 140 to 160, because if it is too low, then renal impairment can happen and cause problems. Regarding the choice of antihypertensive agents, we had the same problem yesterday. There are wonderful drugs, enalapril, which all comes as IV, but here we are using labetalol, NTG and GTN for this purpose. I would love to see when nicardipine will enter Indian market and it will be used. The third aspect is the ICP management, especially when the patient is comatose or drowsy and the GCS is less than 8, then definitely monitoring ICP would be very reasonable. However, studies have shown that placing EVD or measuring the ICP has not, dramatically helped the outcome. It has its own problem. When the ICP you suspect clinically or imaging wise, then you can use either hypertonic saline or mannitol to help with the ICP. In the past, we used to use mannitol a lot. That was the standard of care. In the last 10 to 15 years, things have moved, especially in the neurocritical care scenario. It has moved from mannitol to hypertonic saline. So hypertonic saline is much safer and easier than mannitol. But again, it can cause sometimes circulatory overload. Patient can have congestive heart failure and so on. As long as you are following the protocol, you should be pretty much good using hypertonic saline. Our practice is we start with 3% hypertonic saline at 30 ml per hour. Our goal is reach the sodium to 145 to 160 actually, but in this presentation I will drop it down to 155 because I want to stick with the guidelines.
Guidelines.
But normally I would love to see around close to 160, because from our experience, when I reach 150, 152 also, I'm not getting the good clinical response. So even up to 160 we have reached, and with no major problems. Sometimes people might say patient might be drowsy because of sodium. Unless we reach 60 and above, the drowsiness can be from the blood itself, might not be from the sodium, but again, that is debatable. Now, the way to increase the drip of the normal hypertonic saline is every 4 to 6 hours, you can increase double the volume until you reach 120 ml. To be on safer side, every 6 hours increasing it, doubling the volume, 30 becomes 60, 60 becomes 90, 90 becomes 120. So after 120, I would be a little bit nervous. I have gone up to 150 ml per hour, but by reaching 120, we are usually reaching the goal of 145 to 155 of sodium. Also, you need to keep a close watch. Sometimes sodium might not raise. You need to measure the serum osmolality. If you reach anything between 300 to 310 or even 320 of serum osmolality, it is sufficient. You don't have to worry about sodium. So as long as you reach either of these goals, either serum osmolarity between 300 to 320, or reaching the sodium of 145 to 155, that is enough to keep the ICP under some control. The other option would be mannitol. Again, you can use it in 1 gram. Ideal thing is when the patient is having significant ICP elevation, especially before taking the patient for surgery, we used to give a bolus of 1 gram per kilogram bolus of mannitol and shift the patient for surgery. But again, you can use different dosage. It can be varying from 0.5 gram to 1 gram per kilogram as per the patient's condition. And you can give it as every 4 to 6 hours, or even sometimes 3 times a day or 4 times a day, depending upon the local response. Again, the goal is to reach the serum osmolarity of 300 to 310. Now, regarding other measures for ICP is sometimes we use coma. You can use propofol, and sometimes we can go either for complete neuromuscular blockade in spite of putting the patient on hyperosmolar state with propofol. Still ICP, you feel it's not getting under control, then you can go for neuromuscular blockade. Only problem with that is you're putting the patient at additional risk of aspiration and sepsis and pneumonia. So that need to be looked up for. Other measures we use, which is common for many other conditions as well, is we use DVT prophylaxis with intermittent pneumatic compression. Once you feel that the bleeding expansion hematoma has stopped, then you can use even heparin 5,000 twice a day. However, some people will find this nervous to give heparin in a patient with bleed. So we are not suggesting at this juncture. As long as you're comfortable, you can do it. If you're not, you can just use the intermittent pneumatic compression, that is enough. And any fever should be treated, obviously, with any other medical condition. Keep a patient NPO, because until the patient swallowing gets improved, you better not to give it. Always avoid hyper or hypoglycemia. And also, the previous thought process was to give every patient GI prophylaxis, but recent studies have shown that it should be avoided. You would be, because it increases hospital-acquired pneumonia possibility, C. diff, and so on. So, unless patient you suspect have GI issues, you can avoid this. Regarding the seizures, it's a very debatable. It's been long-standing debate about whether to give seizure prophylaxis or not. In a patient with intracerebral hemorrhage, if a patient has seizures, obviously there is no doubt you need to treat the patient with seizure medications. But as a prophylaxis, it's a very debatable. Current guidelines, American Heart and Stroke Association, we do not, or we don't recommend seizure prophylaxis in patient. Rarely, post-op or even patients has lobar hemorrhage, then you can sometimes consider seizure prophylaxis for a very short duration, but it is extremely physician dependent. Each person have different way of doing it, but the current guidelines does not warrant you to give seizure prophylaxis. But if the patient has seizures, definitely he should be treated. Now, coming to the last aspect, which is surgery. In cerebellar hemorrhage, there is no much of debate. You have to remove the hemorrhage, which is more than 3 centimeters in diameter, and compressing the fourth ventricle and brainstem compression. No questions about it. Patient should have cerebellar hemorrhage. Regarding other is supratentorial ICH, it's extremely controversial. Each person has a different approach. Each institution have a different approach. Some neurosurgeons are extremely aggressive because they go by different trials like Stitch, and they go with MISTRY trial. They feel that mortality was reduced in these particular trials, even though long-term outcome did not change. Sometimes if you choose mortality as your primary endpoint, then definitely surgical hematoma evacuation would be something you can think about. But if you feel you want to change the outcome, then conservative management is as good as surgical management. And regarding again, this some patients might benefit, and you need to reserve the surgical therapy only with significant mass effect and life-threatening bleed. and it might reduce the evacuation, might reduce mortality, but patient should be, if the patient is talking or if he's alert oriented, definitely even though the bleed is very big, they won't recommend surgical evacuation. The patient should have a significant midline shift and also have elevated intracranial pressure, and they should be refractory to medical management. So you need to give some a chance for the medical management to act, or the other measures we talked about, including coma and stuff, before we initiate surgical management, because it has proven that it is not the greatest medical management. The only thing that has helped is mortality. So again, to summarize the point, surgery should not be considered for patients who are fully alert or deeply comatose, because if the patient is extremely comatose, then I think we have missed the boat. Patients with intermediate level of arousal, then they are probably the more appropriate candidates. And patient also, if it's a recent onset of hemorrhage, then that is one thing which supports surgery. And also if the patient is rapidly deteriorating, that's another factor which you might consider for surgery. And especially if the hemorrhage is in the near the surface, it's easier for the surgeon to evacuate it rather than deep-seated ICH, because now when you try to attempt to decompress the brain, you are injuring the surrounding areas or the areas when you try to approach through different route. So it might be very tricky if it's a deep-seated or subcortical hemorrhage. So it's better to evacuate hematoma which is near the cortex. Some surgeons say that it should be a guideline to evacuate temporal lobe hematoma, but again, it's controversial. So then when do you not do surgery, or when don't you consider surgery? Well, if the patient has severe comorbidities, already intracerebral hemorrhage has more than 30 to 40% mortality. And if the patient is having underlying MI, coronary artery disease, chronic kidney disease, liver dysfunction, pneumonia, sepsis, then these patients are not very good candidates. You need to choose your patients well. Advanced age is also another factor to be considered. And also, if it's a remote onset of hemorrhage, then you won't do it, because now you missed the boat and it's too late. And if it's dominant hemisphere, then again, you try to avoid it, because outcome is, as you are aware, it's very poor. And also inaccessibility of the hemorrhage means deep-seated or very deep, it's really brainstem strokes and stuff, ICH, you won't be able to evacuate it. Now, most commonly, traditional surgery was open craniotomy and try to evacuate the hematoma. But recently, endoscopic therapy has come. They try to use fibrinolytic therapy with TPA. They try to dissolve the clot and then aspirate. That also has been tried in few trials. And then you can do CT-guided stereotactic aspiration as well. Now, in patients with a significant ICP, you can consider ventricular drainage, especially in patients with hydrocephalus or trapped ventricle. That definitely helps. It's not only in this condition, but even in big ischemic stroke, we do that sometimes. And intraventricular hemorrhage, when there is intraventricular extension, and if there is a risk of hydrocephalus, then definitely EVD should be considered. That's also extremely important to keep a watch on this. And cerebellar hemorrhage, when you see a cerebellar hemorrhage, do not attempt to do EVD or ventricular drainage, because that can cause supratentorial herniation. So best thing is to surgically evacuate the cerebellar hemorrhage. And MISTI trial results were back in 2016. Again, it was a randomized controlled trial of 516 patients, and they used the minimal invasive surgery versus the standard medical care. And again, at 1 year, patients' outcome were not dramatically different, but mortality was lower in the surgical group, basically. The prognosis, as you are aware, compared to ischemic stroke, the prognosis in intracerebral hemorrhage is very high. Mortality is very high. 30-day mortality can reach up to 50%. But the first 2 to 3 days is crucial, because death happens in these few days or first couple of days. And the risk factors which are associated with poor outcomes are age, Glasgow Coma scale on arrival, increasing ICH volume, presence of intraventricular hemorrhage, and also deep deep ICH locations, and also if the patient was on any oral anticoagulation or other antiplatelet therapy. These are all associated with very poor outcome. So how do you calculate the prognosis? So first of all, you can estimate the hemorrhage volume by using the ABC2 method. So as you can see here, you different slices, you go through it, pick the most the slice which shows the bleed which is at this maximum extent. Then you measure as you can see the A point, measure the longest length, and then perpendicular to that you measure the second one which becomes B, and then you put it in the and you count the slices which shows the bleed, that becomes C, and you divide it by 2. It gives you approximately the cubic mm, and then you know the volume. And then once you get the volume, then you do use the ICH score. ICH score is a very simple calculator. You use the Gostokoma score, you use the age, ICH volume, we just talked about how to measure it, and you check the intraventricular hemorrhage, whether it's presence or not, and then whether it's infratentorial or supratentorial, and you put a scoring system. Then 30-day mortality, as soon as the ICH score starts to increase, then your mortality also starts to increase. As you can see with this scoring system, if you have an ICH score of 1, the mortality is just 13%. Whereas when it's 2, it doubles. When you have 3 and above, it's reaching almost 75% mortality. So it's a very good way of giving some patients some numbers to help in making their decision about continuing care or withdrawing care and so on. One important thing you need to consider is wait at least 48 hours before we start to talk about prognosis, because either patient will be might show some recovery, or patient might deteriorate and die in the first 48 hours. So give some time. Too early initiation of or initiation of DNR status or any withdrawal care may be premature if you start this discussion very early. So at least waiting for 48 hours would be a reasonable time, and they're not making much progress in 48 hours, then you can consider either withdrawing care or having conversation with family. So I'm going to stop at this time, because if there'll be a lot of confusion if we give too much of information. So right now I'm just opening the floor for any questions. And
thank you so much, sir. Now I request Dr. Vinayak sir. Vinayak sir.
It was a nice presentation, in fact.
Yes, sir.
Hello.
Over to you, sir.
Yeah. He in fact, Dr. should cover entire things in the short span of time, and given brief thing about, he has touched all the parts which are to be covered in ICH. I think if any doubts or these things, they can ask us.
Thank you so much, sir. So we have two expertise here. Again, I introduce Dr. Vinayak. That time, sir was not audible. That time, sir is neurosurgeon and specialist in neuroendoscopy. Sir has done multiple surgery in these aspects: neuro, maybe stroke or intrahemorrhage or SH. So is a resource person here. So participant can ask any question they have with respect to surgical aspect or respect in this field. Thank you once again, sir, for again joining us. Actually, I
thank you, sir.
A participant to put the question in the charts, or they come up with the questions directly by putting video on. Sir, first I want to ask one question is here actually. We have Dr. Shushu sir. While doing CT scan, we know that there is a risk of hematoma expansion is the concern here. So there is something called spot sign using contrast. Are we doing it routinely? Is it helpful to us?
It's a very important point. The reason we are not doing the spot sign is it's just going to give you unnecessary anxiety, increasing the cost for the patient, so on. So basically what we do here is we repeat a CAT scan in 6 to 8 hours. That is the standard practice, which I did not say it in the guidelines, because we normally, every stroke specialist and a neurosurgeon wants a repeat CT in 6 to 8 hours to see the hematoma expansion. Let us say that we see that hematoma expansion, or we see the spot sign. What are we going to do is the question. Unless patient you are contemplating surgery, and if you are doing in that aspect, again the 6 to 8 hours we have to anyway wait. So definitely it is more for me, it is more of a research oriented information than actual clinical practice information. But what is helpful when we do contrast study is it will rule out sometimes any AV malformation. Sometimes it will give you some idea about the vascular information. So
Malformations.
definitely it will be helpful, but I won't kind of say that, oh, we have to do CT angio in everybody, because some patients are economically poor, so putting additional burden on the patient might not be in the best interest in certain cases. But if we do CT angiogram on everybody, definitely it will be the ideal thing to do. We do CT angiogram in almost every stroke patient I see in intracerebral hemorrhage patient there, but here
Correct.
I have my practice according to the current scenario.
Depending upon the first CT finding, depending upon the location of the hematoma, also we can decide whether the CT angio is really going to help us, or with our primary CT picture we can compare and decide about the surgical management per se, if there is an increase in the mass effect. Because if it is located near the Sylvian cister or in relation to any of the major vessels, then CT angio has some role, definitely. But if it is lobar hematoma, we have to rule out vascular malformation. If it is a capsuloganglionic, 90% of the CT angio will be normal. That's what we have seen by doing it. If there is suspicion, definitely we do CT angio, sir.
Actually, I want to ask Dr. Vinayak, sir, if
Sir.
if there is a spot sign is positive, when you are given contrast, there is extravasation of contrast into the blood.
Correct.
It will not
correct.
so that there will be hematoma expansion. We can consider this surgery in a near future.
Yeah, if it is going to increase, sometimes because of the tamponade effect, it might stop. Hello?
Yes, sir. Yes, sir.
Yeah, by tamponade effect of the clot itself, that bleeding will stop. If it is going to increase or worsen in the sensorium, then we'll plan. Otherwise, endovascular has a role sometimes in these cases.
Okay, sir. Thank you so much, sir. Dr. Dhaneshwar Kendra, he want to ask how mannitol is useful in ICH. What are the indication? But mannitol crosses blood-brain barrier. Is it worsens the problem? So, Dr. Shushu, sir.
Sure. Well, yeah, I mean, mannitol is a very traditional medication which we have used for decades and decades. And now the hypertonic saline has taken over. In the neurocritical care, we hardly use mannitol. I'm talking about in university setting, in a developed country scenario. Here, I still see that we use mannitol a lot. There is no right or wrong answer. But for me, I feel the hypertonic saline, for me, from my usage, I see it is more safer. It's kind of easy to use. And also the complications are much less, renal complications and so on are much less with hypertonic saline. And so both of them can be used. There is no right or wrong answer. You can use, depending upon your expertise, you can use it. My suggestion is, I think for the audience, I think you should keep an open mind, try it out. It's your own experience.
Correct.
You need to see which one is helpful, and you can always make a point and try to dig into the current literature that will give you more confidence to use it. Because now I think after coming to Gopal Gowda Hospital, I think we are using the hypertonic saline quite frequently. And from what I discussed from the the ICU experts, I don't hear any major complications and stuff. So you can try it out, both of them, and you can even do a simple randomized controlled trial there itself and randomize them to mannitol and and see around 10 patients each and see what is helpful. It is very, keep a research oriented mind and you will have your answer, and dig into the literature that will help as well.
Do you recommend using a bolus dose of depersonase here, sir, in your patients?
Not really. So if you are using the bolus dose, you would do 23%. If you're doing an infusion, then 3% is better. So bolus, you give a very short volume, but you're giving it in a very like at stat you are going to give it. So you use 23%. When you are giving bolus, it's not a very, because the 3% is not helpful because you need to use a big volume to use that. So bolus might not be usual. So if you're using 3%, before the surgery, you would give mannitol like 1 gram per kilogram, you give a bolus, or you do 23% bolus of hypertonic saline
Correct.
and send for surgery. That's the only time we do use bolus, but other times we can go with the traditional 3%, the 30 ml normal saline, hypertonic saline rate, or we can go with mannitol 0.5 to 1 gram per kilogram dosage.
The next question is for both actually. Many patients with on echosprin and clopidogrel, do you recommend using platelet for the prevention of hematoma expansion as a neurologist? And do you recommend platelet in the view of surgical point of view if the patient needs surgery, sir? Both of you can answer.
Well,
yes, sir.
I didn't understand the question. Is
many patients will be on antiplatelets, echosprin especially, and as well as clopidogrel. As a neurologist, do you recommend platelet transfusion to prevent the hematoma expansion? As a neurosurgeon, do you recommend platelet transfusion in the prevention of hematoma expansion during surgery or post-op patients?
Regarding the antiplatelet reversal, we are not transfusing platelets as a standard of care, and the studies have shown it is actually counterproductive. But and only before the surgery, it should be given. They consider platelet transfusion, and Dr. Vinayak can answer that question much better.
Yes. Whenever we are planning surgical intervention, we need to keep the platelets more than 1 lakh. Otherwise, it is going to have a havoc post-operatively. The ooze at the operative site and as well as the recurrence of the hematoma at the operative site is more, which we have come across. So we have made we are following the guideline of transfusion of platelet agents or for every surgical patient who has deteriorated. For those cases, we have made it mandatory to use the platelets before taking up for the case, and post-op immediately we repeat. If it is low, we make one more transfusion post-operatively.
Thank you, sir. From Chirayu Critical Care from Gadag, they want to ask, can you explain about measuring volume of intracerebral hemorrhage? Shishu, sir?
Sure. So it's called the ABC2 method. It's a very easy calculator. So what you do is you have a CAT scan, different slices. Like sometimes it is 16 slices, sometimes it is depending upon whether it's a 5 mm or 10 mm. So you use the slice which has the maximum blood visible on it. Then you measure the maximum length what you find. That becomes A. Then perpendicular to that, on the other longest length you measure, that becomes B. Then you count each slice, and depending upon whether it's 5 mm or 10 mm, you divide by 2. You try to take that number of slides where the blood is visible. Then you divide them by 2, and that gives you the cubic meter, millimeter, or M3, whatever you can call them as, and that gives you the ml, like whether it's a 30 ml, less than 30 ml, or more than 30 ml. But once you start measuring around 10 patients, if you measure, automatically you will know whether it's 30 ml or not, because that is what you require. Because if you say that it's 48 ml versus 68 ml, it doesn't make a difference, because to calculate the ICH score, you just need whether it's more than 30 ml or less than 30 ml. By looking at look at around 10 scans of ICH, you will know whether it's 30 ml or more. So in the beginning, I think you need to do this as for training purposes. But after you do 10 to 20, you know, oh, this is easily more than 30 ml. That is what you require for the calculation of the ICH score.
Thank you, Shishu sir. This question to Dr. Vinayak from Subalata Critical BSS. Sir, what is the rationale for PRBC and FAP transfusion in the treatment of hypotension in neurosurgical patients? Any particular hemoglobin target, as in critical care, that target hemoglobin of 7? What is your take on this, sir?
See, in all neurosurgical patients, post-operatively, we try to keep the hemoglobin at least up to 8 to 9. But the oxygen requirement we want in neurosurgical patients, we feel it is more than any other general the non-neurocritical care cases. That is the reason we insist on keeping at least 9 grams hemoglobin. So we insist for the PRBC in most of the cases.
Okay.
What is the
Thank you, sir.
FFP transfusion, sir? PRBC is agreed,
Yes.
but when
Yeah.
the INR is normal, still FFP are transfused, and we know the INR of FFP is 1.5. We'll never
If
get
the
9
patient, see, yeah, I do agree. If the patient is already on antiplatelet agents earlier, before this bleed, then we insist for fresh fluorescent plasma. Otherwise, we do not usually give it.
Okay, sir. Thank you.
Yeah.
Thank you, sir. This question is for Dr. Shishul, sir. Sir, we have seen in the BP management in ICH, attack, Interact 1, Interact 2. What about Interact 3? Is it come out? And what is the PB target in that, sir? Interact 3?
Well, I haven't dig through the Interact 3 protocol yet, but I will definitely get in touch with you and I'll try to send an email once I get more information.
Sir, there is again, sir, when the BP is high, they say BP is to bring up to 140. Is it to bring
Correct.
up to 140 or than 140? Like, if less than, what is the lowest BP you recommend, sir? Shishul, sir.
So 140 is a good target. So I told you that it's between 150 to 220 blood pressure systolic on arrival. Bring it down to 140 is not a bad idea. And even if it is 130 or 136, it doesn't give you much of a problem. But
Correct.
if the blood pressure is more than 220 on arrival, then bring it down less than 140 would be dramatically poor. The outcome might be very poor for the patient in terms of renal perfusion or even for myocardial perfusion and so on. So if the more than 220 blood pressure, bring it down to between 140 to 160 in the first 6 to 8 hours would be a reasonable thing to do.
Thank you, sir. If you brought BP to 140, how long to be maintained 140? Is this so many days? And to bring to 140, how much time to be taken?
Bringing it down, the blood pressure immediately within the first hour would be very crucial. And regarding the keeping the blood pressure, just like any other condition, from then on, you would like to keep it to the entire length of the stay of the hospital. You would like it to be in the normotensive range. The second day, you can be as aggressive as you want. As long as the renal function is not creeping up, the creatinine is not trending up, you can do whatever you want. But let us say you drop it down to 140 and the creatinine is slightly raising. You haven't given contrast, you haven't given medications, or patient is not dehydrated, and you suspect that this is due to renal hyperperfusion, then you can little bit be judicious in the blood pressure control. You don't have to be as tight as that. So for most part, if there is no cardiac ischemia or renal ischemia and all, you can kind of play around. But that's why after 24 hours, you can be as aggressive as you want, and you don't want the blood pressure to be fluctuating a lot. You want it to be around 140, 80 and below for the better outcome of the patient.
Thank you so much, sir. This question is for Dr. Vinayak, sir. The patient is deteriorating in front of you, definitely surgery is taken, or cerebral hemorrhage more than 3 centimeters, surgery is taken. What about the patients who are stable and hematoma expansion risk is there? What is the timing of that surgery in those patients? Timing of surgery, sir.
See, if it increases rapidly more than 3 centimeters, yes, we opt for surgical evacuation. Or if it remains neurologically stable, no any further deterioration, we closely monitor. Any small dip or variation, we plan surgical intervention, sir.
So you go by clinically rather than the hematoma expansion, sir. That is
yes. If we've always follow the clinical scenario, GCS guidelines and his vital parameters, any dip we'll take. Otherwise, sometimes we manage even the last massive bleeds also we have managed non-operatively, and the patient has improved significantly.
If you see the literature, there is ultra short within 4 hours, not working much.
Correct.
4 to 6 hours.
Correct.
What
if the patient sensorium, if the patient sensorium is holding on, wait. If there is pupillary asymmetry, if there is a bradycardia, any indication, or if you have a facility, if you are monitoring ICP, then you can, if increasing ICP, then you can take a call on surgical intervention at the earliest. But if the clinicals, I always prefer for the clinical condition of the patient rather than immediately taking up the surgical intervention if it is more in size.
Sir, you have done many surgery with the neuroendoscopy. What is
Correct.
your experience? Is there any outcome benefit with the neuroendoscopy?
It is a minimal invasive procedure, and the risk of postoperative infection is very low. And we can keep a drain and come out. We have used streptokinase earlier at the operative cavity. If there is any hematoma or intraventricular, if there is any clot, we used to inject streptokinase dilution.
Go on, sir.
Yeah, we have used, but the overall minimal invasive surgical interventions, we felt it is better over the massive this one, because the only wound repleted the collection, all those things have come down. But overall, if the patient condition is rapidly deteriorating, I never anticipated surgical intervention in those cases of late.
Thank you, sir. Thank you so much.
Yeah.
This is regarding ICP monitoring. Why
Yeah.
to both of us, why we are not doing routinely ICP monitoring? When we know that ICP more than 20 is harmful, we can monitor and treat accordingly.
Two things. Number one is ICP monitoring has not shown to change outcome. So unless you have a reasonable experienced staff and you have, because the risk of infection is there, the risk of another procedure, you can have complications from it and all. And since it has not changed the outcome, we are not using it on a regular basis. But it is something which is reasonable to do. At the same time, it is not warranted. So it's unnecessary procedure. Already patient is in that much of the outcome is already poor. In those cases, no point of doing it. If the patient is in the is very stable enough, there's no point of doing ICP. It's only those middle patients where you are thinking that ICP might go up, and in the intervention patient, at that time we can consider doing this.
Vinayak sir, please, sir, your take on.
Correct. The main thing is ICP. Putting the ICP monitor is not that this one. The thing is monitoring it off, and the staff. We do not have the adequate staff to monitor it. And one more thing, if there is any small aseptic precautions, if there is failure in the breach of aseptic precautions, rate of infections is very high. That is the only reason we are not using it at present, in fact. And more of the modality of treatment at the end, it has not helped much.
Okay, thank you so much. Just Dr. Pawan Yammar, you want to ask, is there any role of dexamethasone for cerebral edema due to intracerebral bleed?
Yes. Well, there are two edemas in the brain. One is a vasogenic edema, another one is a cytotoxic edema. When you have vasogenic edema, which is seen in oncological patients or any kind of other vascular conditions or blood or significant disruption of blood-brain barrier, steroids, mannitol, hypertonic saline, all have a role, or even sometimes anti-inflammatory drugs have been used, antioxidants have been used. But there is no role of any steroids, mannitol, or hypertonic saline, or anything else in cytotoxic edema. So even in patients with stroke, ischemic stroke, we opt for just decompressive hemicraniectomy, and we are just buying time using hypertonic saline or mannitol. So cytotoxic edema is very, very, very difficult edema to control. Whereas with the tumor and so on, you can give this dexamethasone. It helps immensely, even in spine or in the brain. It is an amazing thing because there's a lot of vasogenic component. When it's a cytotoxic component, steroids or any other stuff is not going to help.
As such, I think Dr. Shushruti is correct. The dexamethasone or any steroids are useful only in vasogenic edema, that is tumor-induced or infective. When you are planning treatment for the infection, you are targeting infection. But rest of the post-traumatic or hypertensive bleed associated bleeds, there is absolutely no role for the steroids as such. In fact, it causes infections.
Thank you, sir. Thank you so much.
Yeah.
Dr. Shushruti, sir, you mentioned during presentation about the comes, I think K-tetra, I think, what is it, a protein complex?
Yes,
protein
it's a four protein complex. Okay. So it's a case center. So it's different agents are used in different hospitals. So you can use any of that which is local available. So fresh frozen plasma does the trick. Vitamin K does the trick. If you don't have a blood bank and so on, you have to go with whatever you got and move on. Or you can arrange things to happen from other hospitals and so on. So we can probably develop a protocol, or if already the protocol is in place, then we can follow that protocol. Or if it's not there, we can find out what is available in our resources and then make a protocol of our own.
Just to add to this, sir, FFP and protein complex you play. PCC is better than FFP because we are using lesser volume, like 20 to 40 ml. It acts faster within minutes. As FFP requires larger volume, it takes few hours to 1 days sometimes, and there is a risk of infection problem also. So there is no study that says comparing FFP versus PCC, but definitely PCC is slightly more better than the FFP. That's the main given. Sir, what about dabigatran? You are using a lot about dabigatran, and there is a bleed is there. You mentioned about activated charcoal can be used if you use early, and also hemodialysis. What is your experience that dabigatran induced bleed?
Yeah, so dabigatran induced bleed, because I think we should talk about this, because that is the most commonly used anticoagulation at this point of time, other than the acetylene. The next common would be dabigatran because of the cost of the rivaroxaban and apixaban. Dabigatran is probably the cheaper one.
Cheaper.
The issue is with any oral ingested medication, the first couple of hours, activated charcoal has a role. Otherwise, after that, then there is no role of that, number one. Number two, Pradaxa itself, or dabigatran itself, has a specific antidote. So you need to give that to reverse it. No other, you can do dialysis and so on, but that's not the effective one. If you have the ability to give the antidote, that will be the best thing.
Have you used the antidote, sir, in USA?
We do it all the time, but unfortunately or fortunately, we have moved away from Pradaxa or dabigatran. We hardly use it because it's all insurance covered. Either we use Eliquis or Xarelto. Most of them, the highest used drug is Eliquis, which is rivaroxaban, and then apixaban. The next would be the rivaroxaban, which is Xarelto. So the chance of using Pradaxa and the chance of using the antidote doesn't arise at all. At least now it has dramatically dropped. You can see the graph in the developed world that they have moved away from Pradaxa. We had a lot of bleeding issues with the patients and the renal issues with the patients, so we are not using it.
How do you manage rivaroxaban or apixaban induced bleeds, sir?
So there is no specific antidote for it. We can use again K-centra, we can use fresh frozen plasma, PCCs, whatever is available. So we need to come up with a protocol so that we can kind of come up with, because we might get probably once a year or maybe once in 2 years this case. So we should not be kind of lost in that thing. So if we have a protocol for each one of the newer anticoagulants and also heparin and low molecular heparin, then that's the best thing to do.
So there is a basic question actually. How to identify arterial bleed versus venous bleed? Dr. Vinayak sir, how to differentiate arterial bleed versus venous bleed in CT?
I think we have to do a CT angio to confirm it. CT angio will clearly tell us where is the leak. We have to identify the leak and we have to plan accordingly, which is the feeder in AV malformations. If the aneurysm, we have to identify and the CT angio, then take a decision about it.
Okay.
A CT angio is very tricky because if you do too early, because of the presence of the large bleed, you can miss small AVMs and other structural abnormality. So doing it too early is also sometimes can be tricky, but it will give you other information if you have vasculitis, if you have venous thrombosis, if you have any other feeders. So it can give a lot of idea, but at the same time, you need to be careful. If it's done too early, then, because at that time, irrespective of the bleed, you're not going to intervene and do things. But if you're suspecting vasculitis and other venous thrombosis and all, then you better do a CT venogram or angiogram.
Venogram.
So sometimes even heparin should be given for venous thrombosis, not sometimes. In every patient with cerebral venous thrombosis, we should give heparin. So it will be very beneficial to confirm whether there's a venous thrombosis or not. So sometimes if you suspect, that's why history is very crucial to see whether patient will benefit with CT angiogram or not.
This is from Dr. Lakshmikant. When to start antiplatelet agents post ICH?
Restarting the antiplatelet agents depends on why you are starting it. So if it's a coronary artery disease, active MI, patient is having other comorbidities which warrants the immediate initiation of antiplatelet therapy, the neurosurgical consensus is you can wait up till the bleeding stops, 24 to 48 hours or even later, the 2 or 3 days, you can start it unless the benefit outweighs the risk. But if it's anticoagulation, surgeons would like to wait at least 4 weeks, repeat a CT head, and then take a call.
Vinayak sir, please.
Yeah, I do agree with it. Correct. I do agree with the same. Yes.
So antiplatelet after 2 to 3 days and few weeks for anticoagulants. That is the message.
Exactly, sir. Exactly. If really indicated the benefits over, because the cardia is a priority, we have to explain both and then take a decision about it.
And the lowest possible dose would be beneficial.
Correct. Yes, sir.
Regarding same, actually one question is there for DVT prophylaxis, when you will start in ICH patients, sir?
As soon as the bleeding is stopped, you think that imaging wise or neurologically, then you can start the DVT prophylaxis. But you don't have to give heparin if you're nervous. You can easily get away with just intermittent pneumatic compression. That is enough from the guidelines itself. But if you want to really say that this patient is a very, very high risk patient, you want to initiate, then you can give after the 24 to 48 hours once you think that bleeding has stopped.
Okay, thank you so much, sir. Even recommendation is 1 to 4 days you can start DVT prophylaxis. Earlier we used to wait a longer period.
Usually we are starting usually after 48 hours most of the time now.
After 48 hours.
For our cases. Yeah.
Dr. Bhaskar, do we need seizure prophylaxis in all, sir? I think it has been answered in the presentation.
Presentation itself, correct.
Yes, not required as a prophylaxis. If definitely seizure is there, yes, give. If there is easy showing seizure, yes, we can give seizure medication, not prophylaxis, we can say. This is one question, sir, for Dr. Vinayak, sir. If there is intraventricular hemorrhage is there, what is your experience of using IV RTPA intraventricular administration to clearing?
This one, I have never used this RTPA intraventricularly. We had used streptokinase, in fact, by putting a EVD, but RTPA I have not used.
Yeah, some trials have shown that instilling if to the hematoma core and thrombolizing the hematoma, because it becomes easy to drain, because when the hematoma is formed, it is very difficult to drain it out with endovascular approach or like microvascular approach. So they would instill the TPA, because TPA is much more faster than streptokinase, especially in the clot resolution. So it might be helpful. Regarding the installation of the IVH, there are certain studies which have shown that, but it requires a lot of expertise and experience. So it has to be done multiple times and in hundreds of patients before you can, initiate those interventions. But again, the outcome is, first of all, before you go in, first of all, you have to make a point whether it's worth it to go or not. So because there's only a very small population of patients which intervention is required, especially in ICH. So you need to choose the patients well. So I think the traditional approach of evacuation of hematoma as minimal approach as possible, like either endoscopic wise or small, minimal invasive procedures should be used to the hematoma evacuation. Regarding instilling TPA or instilling streptokinase and all are very tricky, and it can go either way. So you need to be careful in that aspect.
Thank you so much, sir. If any other question from the participant, please, they can chat or they come up and they can ask themselves. From Dr. Shobha, can we use antifibrinolytic agent regularly in all hemorrhagic patients?
No,
This one, tranexamic acid.
yes, we can use. In the patients with not in every regular patients, only if you are suspecting patient has received heparin or any other, TPA or any other blood thinners, then you can use it, but not regularly in every patient. It has not shown any benefit.
Thank you, sir. If any other questions, participants, please. Role of neuroprotective agents in ICL, sir.
Still, it's a debatable. One thing which I have seen, I have practiced without neuroprotective agents and with neuroprotective agents also. One thing which I observed is by using neuroprotective agents of late, the morbidity has definitely come down. Patients' rate of improvement is faster with neuroprotective agents, which I have noticed, than but overall outcome, if you compare over a period of 6 months or something, it remains same whether you use it or not use it. But definitely the improvement from the morbidity is definitely faster with available, whichever were present available in the market. With them, I have found it is useful to use them when they are available. What I don't know about Dr. Shushruth's experience, but whatever,
yes, sir,
I have found it. When I started practice, there was none of these were available, in fact. But now we are using, definitely the morbidity rate of improvement is faster. That's what I noticed.
There is a lot of neuroprotective agents. There is ceticolin, there is piracetam, there is garlic, there is turmeric, there is coenzyme Q. There are a lot of magnesium. There are a lot of neuroprotective agents. But unfortunately, none of them have passed the randomized controlled trial phase, at least for now. And thousands and thousands. There are 1,918 chemicals have been tried in stroke patients. And there are only 3 which have shown benefit. One is TPA, one is antihypertensive management, antiplatelet therapy, and statins. Except these 4, there is no other treatment has shown outcome difference in any other respect. So right now we reserve the neuroprotective agents to the individual practice. We don't, as a stroke neurologist, we don't recommend. First of all, there is no neuroprotective agents in the United States market. So unfortunately, my majority of my experience is in the United States. Here is I'm only 1 year of practice. So in neurological world, I mean to say. So I have zero experience. So there is no in the Europe market or in the US market, there is no neuroprotective agents. So there is no point of even discussing that whether it's used or whether it's a pass. But none of the agents, as far as I know, has passed the RCT phase. So it's all left to the individual practice.
Okay, thank you so much, sir. Another question actually. Yes, sir. Yeah. Please, sir.
Yeah, that's what. Just wanted to know the steroid of choice for vasogenic edema and its doses.
Okay, steroid of choice for vasogenic edema.
It depends. It depends on which condition we are talking about. If it is due to MS, multiple sclerosis, then definitely you would use Solumetrol, as the treatment of choice. Let us say you're considering a tumor. I feel that dexamethasone might be a better choice. So it depends on, or if it's due to meningitis and you want to prevent complications from that. Again, you can use either prednisone, Solumetrol, or dexamethasone. So it depends on which condition you are talking about the vasogenic edema. So that is what my take is. Again, Dr. Vinayak can elaborate on from his experience.
No, actually, Dr. Shushruth, we have a patient at present who's got an SAH. Actually, she was improving, then again she deteriorated suddenly since yesterday. Repeat CT shows a huge vasogenic edema. Now, what should be the steroid of choice for that?
Did you say subarachnoid hemorrhage?
Yeah.
Okay, and the reason of subarachnoid hemorrhage, traumatic or aneurysm?
Actually, this CT angio has not shown any aneurysm also. It is more of a. She is around 65 years. Parietal and high parietal SH it was.
SH, but it's you can use dexamethasone, but I don't think it has any role in preventing this or in preventing any complications and so on. I mean, I need to look at the image to see, what might be going on, and
I will share.
also I would check the venous phase of that
Correct.
CT angio, because sometimes you have this blockage of the venous tract, which can give rise to back pressure and cause bleeding in that particular location. So the two things you might help is, if you have some soft tissue edema in that area, probably fall, even though you don't have history, fall might need to be considered, trauma should be considered. If there is none of that, then try to see whether that is due to like any venous blockage, so venous thrombosis or something like that might be helpful.
I will share the images to your WhatsApp later.
Sure.
Yeah.
Okay.
Thank you.
Shobharan, you want to ask restart of anticoagulants in prosthetic heart valves?
Sure. Well, that's what we talked about this. So if the risk or a benefit outweighs the risk, then you would wait until at least 4 weeks to restart, especially in atrial fibrillation patients. You would wait at least 4 weeks and above. But if in cases with valvular conditions, it is a little bit tricky. So what we do is we wait at least 4 days or at least few days till the bleeding stops. Usually what we do is we start with heparin drip, keep a very close watch on the bleed. If there is no expansion of hematoma, then over a period of time we change it to low molecular heparin and eventually start azithromycin, because it's very difficult to reverse azithromycin and low molecular heparin in comparison to heparin. So we would start with heparin drip in 4 days and then take it from there.
Thank you so much, sir. There is a one question on prognosis. You told when patient ICH you have to wait for 48 hours. Why that is so?
Unless the patient has no brainstem signs and brain dead examined, then you don't have to wait. But if there is certain brainstem function still left, you would kind of wait to see how the swelling progresses, whether it's getting better, whether it's resolving, whether it's worsening. And then in 24 to 48 hours, you get a reasonable idea that the prognosis is and also sometimes when the patient presents with the bleed, they are extremely stuporous and comatose. So the neurological exam is a little bit tricky. So once you wait for 2 days, then you'll have a better neurological exam, and then you can probably make a decision.
Thank you so much, sir. I think most of the questions has been answered. I'll request Dr. Vinayak, sir, for the final message here for all the participants. Dr. Vinayak, sir, your message, sir.
See, most of the things for the ICH etiology, pathogenesis, management, evaluation and management, everything has been covered nicely. I think we need to practice. It is a patient to patient. It differs depending upon the presentation, etiology. We need to take a decision individually, each patient, and follow the protocol and guidelines. If any things we need to discuss and take a decision each other.
Thank you, sir. Dr. Susu, sir, your message on this, sir.
Well, ICH is a very bad prognostic condition to begin with. So in this, the aggressive approach and and use some empathy with the patients and also use the guidelines would definitely help in changing the patient's outcome as well as family's outcome. So I would highly recommend this audience here to read about the literature about the current guidelines and use it in your current practice. That will definitely help the patients.
Thank you so much, sir. As a critical care point for all the participants, the most important I feel is to manage BP. As a critical care person, the BP should be achieved target as early as possible to avoid the expansion hematoma. You ask for arterial line drugs and try to do it as soon as possible. More the BP higher side is that the chances of outcome hematoma expansion outcome will be not so good. And most important from our point of view is reversal of the oral anticoagulants or heparin or maybe newer oral anticoagulants, that to be treated aggressively either with FFP, PCC or even vitamin K. What are the available here? That to be done. That is another important. And calling for the neurosurgeon if there is a patient deteriorating again for getting the outcome benefit. I think these are the important points along with the airway breathing circulation management. We are discussing in another session actually how to manage critical care points in all neuro patients, that we are going to discuss in other session. And we will end up here. If there is no other question, I think thank you once again, Dr. Shushu sir and Dr. Vinayak sir. It was definitely a fantastic discussion, actually, interaction with all the audience participants. Thank you so much for your time, sir. Thank you.
Thank you.
Thank you, sir.
Thank you. Thank you, sir.
That's